Good morning, everyone. My topic is about the brain mets in HER2-positive breast cancer. And initially, the first is the Patricia trial. It is basically the final efficacy data. The earlier data has been presented, and this study has studied the high-dose trastuzumab in combination with pertuzumab. So what is the background? Basically, it is, as we know, that 40 to 50% of the patient with HER2-positive disease has somehow brain mets, which have a shorter survival and reports a poor quality of life. And this study was based on the preclinical data that high-dose trastuzumab would be efficacious in the CNS for patients who had progressed on standard dose. Means the patient has received initial trastuzumab, and further increasing the dose may have some effect. And the initial study has shown at a median follow-up of 16.6 months that the confirmed overall response rate is something around 11%. And the patient is having a clinical benefit rate of around 68% at 4 months and around 51% at 6 months with no new safety signals. And thereafter in June 22, NCCN has adapted this also, that you are giving a high-dose trastuzumab as a new category 2 recommendation for patients who have progressed on initially trastuzumab. So this was a study design where they have taken all the metastatic HER2-positive breast cancer patients who have progressed. But important thing is all patients have received initial radiotherapy and have got a stable systemic disease for them. And the pertuzumab dose is the routine dose every 3 weekly. But trastuzumab, the dose has increased to 6 milligram per kg every weekly. So that has been done. And that they have treated till progression with the primary endpoint of overall response rates and secondary being the duration of response and the clinical benefit rate with CNS and systemic PFS and patient-reported outcomes with safety data. So, but it's a very small study of only 40 patients, and out of which 39 patients have received this trastuzumab and pertuzumab. And around 28 patients has finally discontinued the study with death occurring in 20 patients and progression in CNS progression in 27 patients. And at the time of disease, study closure, 2 patients were still on the study, with surviving more than around 4.2 months. So if we see the baseline demographics, it is more or less same. The important thing is only the time all have received prior radiotherapy, and the median duration from radiotherapy to enrollment in the trial was 18 months. So the effect of radiotherapy is basically curtailed in this trial. And most of the patients were on concomitant anti-epileptics, which I'll explain later. So this is the further 21-month follow-up data. So they have shown that the 39 patients have complete treatment. In this follow-up data, the median CNS PFS is again 4.6 months, and the median overall survival has increased 27.2 months in these patients. And the confirmed overall response rate is around 11%. And importantly, they have lastly shown that 2 patients have survived for 4.1 years and 4.8 years after given this therapy. So what they have shown that if the patient have received previously trastuzumab and pertuzumab, out of 19 patients, 47% have received. But if they have received only trastuzumab earlier, they have a 73% clinical benefit rate in this subset. And those with TDM1 has got 47% and neratinib around 60% response rate. So, and they have also done a subgroup analysis, but it's so small a study, it's very difficult to say, but it has shown that of the patient who have on concomitant anti-epileptics, they have got a poor 62% response rate as compared to 87% without that. Those who have a concomitant systemic disease has a poor response. Those who have received corticosteroids have a slightly poor response. Hormone receptor positive, more or less same. And the performance status also has slightly, if those with a poor performance status has a poor response. Adverse event, they have said that the grade 3 to 4 adverse event is only 7.7%. That's the most important, that even after increasing the dose, the adverse event profile has not been much increased. Most common grade 3 4 adverse event were gastroenteritis, headache, hydrocephalus, and hypertension. So cardiac issues were not even by increasing the dose in this subset of the patient. So it has been shown that this the median time from last radiotherapy was 18.6 months. So this study says that it is not attributed, it is the response is only due to the systemic regime, not due to the radiation therapy. And as we know in the case of the brain mets, already discussed the studies, the HER2 CLIMB study, which has taken the tucatinib, trastuzumab, and capecitabine, it has also reported a 1-year PFS of around 24.9% and a median PFS of 7.6 months. And has an OS advantage. So where to place this Patricia? Because this study was started at that time when no drug was there for brain mets. So they have said that might be after tucatinib, trastuzumab, and capecitabine, you can sequence Patricia. But thereafter came other studies like Cleopatra, which has already been discussed, where the pertuzumab has been added to trastuzumab and docetaxel, and it has shown that adding pertuzumab also delayed the time to onset of the CNS disease with a significant hazard rate of 0.58. The Camilla study, which was also shown that TDM1 treatment resulted in further regression in the patients with HER2-positive breast cancer. Now the Destiny studies, also in the breast 3 trial or all these, shown that 63% of the patient with TDXD has got a brain response as compared to 33.4% with TDM1. So all the in the TDXD in now the new trial, Tuxedo-1 trial also confirms the Destiny results, showing that in the trastuzumab direction, when used, the intracranial response rate is something around 73%. So they are the new regimes which are being coming. So if we see whether to keep this Patricia now, might be in the resource constraint setting or some are not available for others. But the important thing is grade 3 to 4 toxicity. For the Patricia, it is something around 7.7%. With the HER2 climb, with tucatinib and capecitabine 60%, with cape alone that is 51%, and with TDSD also the grade 3 4 toxicity is 45% and TDM1 39%. Treatment discontinuation rate, if you see, Patricia only 5.1%. With tucatinib 5.9, capecitabine addition 11.6, and trastuzumab 13.6% is the discontinuation rate happens in the trial with Destiny 3, and TDM1 further 7.3. So all these things may lead to you can continue with this trial in some restricted patients. Limitation is small sample size, and all the patients had basically it's a small subset of HER2 positive that who have prior radiotherapy, documented disease progression in the CNS, but is stable extracranial disease. But after this, neosystemic therapy has been included. So we say that high dose trastuzumab combined with 3 weekly pertuzumab may be associated with a high rate of clinical benefit, including radiographic stability and maintenance of quality of life. The next study is the pooled analysis of trastuzumab deruxtecan in patients with HER2 positive, and it's basically they have taken all the 3 Destiny breast 1, 2, and 3 data, and they have done an extrapolative analysis in this subset. So they have said that the trastuzumab deruxtecan is approved for treatment, as we know, for the HER2 positive unresectable disease, but exact data in the brain mets is lacking. So the efficacy has not been fully established in this group of patients, and so they have done this study. So they have defined the brain mets as a treatable or stable brain mets in which the patient had received prior CNS directed therapy and the CNS disease is found to be stable. Or the other is the untreated or active brain mets, where the patients have new brain mets or progressive brain mets that have not been subjected to any CNS directed therapy initially. So the inclusion criteria, as we say, that is the Destiny breast 1, in which they are asymptomatic, previously located and stable brain mets, and in Destiny breast 2 and 3, the patient have previously untreated and asymptomatic, and patients were there. So both active in these studies, they have both active brain mets as well as stable brain mets patients they have taken. So it's a mixture. So this retrospective exploratory analysis has taken all this breast 1, 2, 3 studies, and they have pooled the data from those patients who have received trastuzumab deruxtecan and the comparator pool. And so they have increased something around 1,600 patients in the subsets and taken the intracranial overall response rate and the duration of response they have taken along with the CNS PFS benefit in these patients. So the demographic characteristics, if we see from the baseline characteristics, the brain mets pool in the Destiny breast 1 is something around 12% patient, and in the breast 2 56 and breast 3 31% of the patient. Along with the regional variation, we say they have taken from all the Asian population something around 36% of the patient in this subset. So they are well balanced in both the subsets. And the important thing is the patients in the brain mets pool tended to have a longer time from initial diagnosis to randomization. So that is the thing that they have something randomized around 56 months as compared to 50 months in the patient in the non-brain mets pool in these patients. And patients with recurrent metastatic brain cancer is the majority as compared to the de novo. So de novo breast cancer is something 30%, and recurrent breast cancer patients were 60% in this subset. And the visceral disease were present in something around 96% in the brain mets pool patient, a higher number, as compared to 76% in the non-brain mets pool. So the prior systemic therapy, if we see, so in the trastuzumab deruxtecan cases, the most patients have received trastuzumab 96%, pertuzumab 70%, TDM1 70%, and other TKIs around 12% of the patients have received. So overall, the patients with brain mets were heavily pretreated with a median of 3 pre-systemic therapy they have taken. And in both the groups, the 70% have got treatable or stable brain mets and 30% have active brain mets. So they were well balanced. So the exploratory best intracranial response they have seen is in the intracranial thing is something around 45% in those with the stable brain mets or treated one. And in the untreated, they also is something 45% response they are found to be seen in this subset, with around 15% having a complete response rate, as compared to the comparator pool where only 27% of the patients is having a response. So the best percentage change, the shrinkage was more prominent, whereas in the comparator pool, the brain met shows less of a response. And exploratory CNS and PFS data also shows 12.3 months benefit as compared to 8.7 months. And the sites of the first progression is intracranial is around 25%, and extracranial it is 32%.
Please come to the conclusion slide.
Yes. So the safety data are same. And so we will say for the stable brain mets, the intracranial overall response is 45% as compared to 27%. And for the active brain mets, it's also around 45%. And numerically, longer median CNS was observed in the patients with treatable stable brain mets disease. And so it found that TDXD is an effective treatment option for HER2-positive metastatic breast cancer, both in the active disease as well as the stable treatment disease. Thank you.